and go fast, though. The first one is a case of intermittent episodes of fatigue and weakness. So this young boy was born a little bit early and did have a brief NICU stay for some issues with choking on some food, saliva, swallowing issues, but eventually those resolved and he was able to go home and ultimately ended up feeding and growing well and met his motor milestones on time. Did have some speech delay, had an IEP in place though, and that resolved. Around age 3 though, his parents noted that he had intermittent episodes of fatigue and weakness. And the weakness they really talked about was like a change in gait and like his belly sticking out. But mostly he was complaining of, my legs are tired, and then they'd rest him for a bit and then it would get better. He was sad because he couldn't play soccer with his peers, and ultimately he was getting OT in school for some fine motor issues and getting PT in school for some leg strengthening. Academically he was doing well, and he was then seen by the first neurologist that met him. And so this is kind of a combo exam of my exam and the first 2 neurologists that saw him. But I would say he did have slight pes cavus. Mental status was normal. Pertinent cranial nerves is that he did have a high arched palate. He did have mild bilateral ptosis. When I saw him, I noted some proximal muscle weakness that wasn't noted by previous folks. Neither were the cranial nerve findings. And what was noted by previous folks was that the exam at rest was normal, but when they got him up to exercise him, that's when they noticed foot drop and lordosis. I noticed that at rest in him, but I saw him many years later. And then his reflexes were normal and his sensory exam was normal. His 100-meter walk time was 92.1% predicted, so that's good. And then the neuromuscular GROW is a motor outcome score that we use with a max of 100, so also he scored very high on that. So functionally was doing fairly well. So the differential diagnosis, the first physician just thought periodic paralysis, told him to try some diet changes. They stuck with that doc for a little while, noted continue issues, then went to a second physician who thought maybe it's mitochondrial. Makes sense, some fatigue, you could think that. Started him on some supplements, but I think what's noteworthy about this case is what was left off the differential. So anytime we talk about fatigue, we've already talked about this today in these cases, right? You think about myasthenia gravis or you think about a congenital myasthenic syndrome. I've got this table up to highlight some key differences that I think about in the history that might make me lean one way or another, but these are not hard and fast, right? There can be subtle changes that somebody with CMS has that fit more with acquired myasthenia, but these are just general things that may help you guide yourself one way or another. For time, I won't go through it. So this child ended up having mitochondrial DNA testing sent by that second physician, but he also luckily sent whole exome sequencing. And there were 2 variants found on the SLC25A gene. One was listed as pathogenic, one was listed as a VUS. However, there were case reports in the literature with others having one change. This one change in combination with another that were symptomatic, so we thought it was probably a good fit. And this can be associated with CMS type 23. It's also associated with a very severe mitochondrial cytopathy. So classically, when people see pathogenic variants in this gene, they think of that. They don't think of the subset of kiddos who have potentially some mild intellectual impairment and then CMS type features. So this graphic I'm not going to spend a lot of time on, but this on the left is showing the neuromuscular junction, all the proteins that can be involved. You can see that the SLC25 is presynaptic, and then on the right you're seeing that the SLC25A1 is responsible for mitochondrial citrate transport. So when I met the family, they had this diagnosis. That's why they finally made it to neuromuscular. And so we discussed 3 potential treatment options. They ultimately felt more comfortable starting with Mestinon. I know it's presynaptic, but parents wanted to try and see with Mestinon how that went, and they actually saw some benefit. He was able to start to play some of the soccer games with his peers. Eventually, though, they thought there was more room for improvement, so we added liquid albuterol, and they've been very happy with that. He's now playing golf, considering maybe doing competitive golf next year. He's playing soccer the whole game at school with his friends. He's able to play violin and is in the choir. And then now also when they go on vacations, he's more able to enjoy the amusement parks with only a few brief breaks than he had been in the past. So the key takeaways for this point: important to think about a differential diagnosis, not really anchoring on a diagnosis right away. If there's any trainees in the audience, I like to, when I see the chief complaint, come up with a differential that includes lots of things and sometimes not even neuromuscular, right? Because sometimes other subspecialties of child neurology make it into our clinic. And then I always like to ensure that treatable conditions are not missed. However, keeping in mind the prior case, you don't want to anchor on something that's treatable and not fully expand. And then also I think it's very important in a child who has respiratory issues around the time of birth, like this young boy did, and a high arched palate. I really think congenital myasthenic syndrome's got to be on your differential. It's treatable. You can make a big impact in quality of life. So that's the first case I went through really fast. Any questions?
Please go ahead. Take one.
A couple of questions. A very interesting presentation. But I was wondering about, do you have an MRI of the brain? Some of those patients with citrate carrier deficiency have very thin corpus callosum, and I wonder if you find that. And also if you have some electrophysiology, like repetitive stimulation.
So he has not had an MRI of the brain. There are reports of individuals having mild intellectual disability, and like you mentioned, I haven't pushed for it yet because I don't love to sedate children when I don't feel like it's going to change my management, but he is now coming to an age where that is something that could be done. And his parents have been resistant to do the repetitive stimulation just because he's responded so well to treatment. And when I first met him, I wanted to start on treatment rather than let's do, electrodiagnostic studies and see how it goes.
Along that same vein, I've had at least 2 cases where they've had brisk reflexes, and I was wondering if you've experienced that, and these 2 cases didn't have any HIE or an insult.
I have had children with just the general congenital myasthenic syndrome diagnosis, yes, having easy to elicit or brisk. This young boy did not. And I haven't seen it in relation to any significant hypoxic ischemic events at birth. Next. Okay. All right, so we will move on to the next case. And so this one is just, gave it away, but symptomatic 5Q SMA in the era of newborn screening. Yes, it does still happen. So this child was born out of state in the summer of 2021, and she was born full term. It was no issues with the pregnancy, and she met her milestones until about 8 months of age when things started to become problematic. And at 9 months, she began having trouble pushing herself up. She stopped bearing weight on her legs, and she started to hate tummy time. So she was referred to physical therapy by her pediatrician, and there were maybe some small improvements, but not really significant. And then her fine motor, social, cognitive development was all within normal limits. So on exam, there was nothing in her general examination that was worrisome. Again, I thought she was cognitively normal. She was able to sit unsupported, but she did not bear any weight. And then I thought her shoulder abduction was about a 2 grade, so proximal weaker than distal. I'm just going to go through a quick. She did not have any reflexes. Her sensory exam was normal. We did the Bailey motor on her, and her scaled score was 1, so very low. And we again did the neuromuscular GRO, and that was also low at 33. So a brief differential. We should still think about SMA. I'm going to go into that a little bit more. Her legs were more involved than her arms. Her arms were involved, so maybe SMA lower extremity dominance on the differential. Maybe some sort of motor neuropathy is on the differential. And why is SMA on the list? Every state is screening now, so do we really need to think about this? And yes, we do. I mentioned that she was born out of state, right? So every state has started implementing it at different times. So you need to know if you are seeing somebody from out of state when it was implemented. Is it in the pilot phase or is it in the official phase? We had some children in Ohio who we were still in the pilot phase. We ran out of some reagents. Children weren't screened for a couple of months. Nobody was notified. And so we had a couple symptomatic kiddos diagnosed because of that. And then we all know that the newborn screening varies from state to state in terms of what's done, but it is looking for the homozygous deletion. And there are some children that will have one allele that's the deletion and another that's the point mutation. And then it's possible, did the lab forget to notify somebody? Was there a reporting error? We just have to be mindful of that. I think that's uncommon, but can happen. So I just want to highlight that even if you got a report that was negative, you still need to think about it. Or if you didn't get any notification, you definitely have to think about it. So it's reasonable to test. So in this young girl, we did send the diagnostic testing. She had 3 copies of the SMN2 gene, and she had the homozygous deletion of the SMN1 gene. She did have newborn screening done in her state, and it was reported out as negative. We don't quite know what happened there. We talked about treatment options. Her parents were very interested in onasemnogene. However, because we wanted her to start treatment as soon as we could, we took advantage of the risdiplam free drug program while we were working on the onasemnogene approval. And ultimately, she got onasemnogene, 1 month after her diagnosis. So again, we used the GROW a lot. And so I'm showing you her GROW score pre-treatment and then the improvement seen post-treatment. There's improvement seen, not as dramatic as we would like. Her parents note that she's stronger in her upper body. She's lifting heavy objects overhead now. She is starting to bear weight, but needs significant assistance to stand and take steps. And then this is an image from our follow-up paper looking at the children that were treated with onasemnogene. And I'm just highlighting in the red box here all the children who were identified off newborn screening with 3 copies of SMN2. And the white circle is when they got their treatment initiation. And you can see for anyone who's treated within the first month of life and 3 copies of SMN2, sitting is the triangle. They're all sitting on time. That's not what's important. But the walking, they're all walking within the normal expected range. And so she's very far outside of that now, but gaining skills. So the takeaways from this is newborn screening is great, but not perfect. Symptomatic SMA diagnoses will still occur, so we need to think about them, even though they are going to be rare. And then as we are all learning and know pretty well, I think by now, treatment as early as possible is really how you get the best outcomes. So it's just kind of sad for this young girl that she didn't have that opportunity. And that is all. Any questions?